Dr. Orville Campbell. Today, we will cover the topic Chronic Kidney Disease Structured Collaborative. This is Session 1. Identify patients at risk for the development and progression of CKD. These are the objectives for Session 1. What is chronic kidney disease? Who should be screened for CKD? What are the risk factors for progression of CKD? Here's a question to consider. Can you identify two modifiable risk factors and two non-modifiable risk factors for the development of CKD? CKD prevalence. The burden of chronic kidney disease, about 1 in 7 adults have CKD or chronic kidney disease. That is 15% of the U.S. adults, or 37 million people. As many as 5 of 6 adults with moderately reduced kidney function, stage 3, in other words, do not know they have chronic kidney disease. More than 661,000 Americans have kidney failure. Of these, 468,000 individuals are on dialysis and roughly 193,000 live with a functioning kidney transplant. Diabetes and hypertension are the most common causes of chronic kidney disease. Mortality rates with chronic kidney disease worsens as you progress through the stages of CKD. In other words, the higher the stage of CKD, the greater the mortality rate measured as events per 1,000 person years. Comorbidity burden in CKD. Where there is no CKD as it relates to the comorbidities, diabetes, atherosclerotic heart disease, and heart failure, 30% with one comorbidity. If there's CKD present, then 70% of persons or patients have one comorbidity. Cardiovascular risk and CKD. As CKD progression occurs, i.e. as measured with GFR, cardiovascular risk increases. In other words, if you have an eGFR greater than or equal to 60, your cardiovascular risk is 2.11. However, if that eGFR is less than 15, then your cardiovascular risk jumps to 36.6. What is CKD? The Kidney Disease Improving Global Outcomes, or KDIGO, definition for CKD is abnormalities of kidney structure or function present for greater than 3 months and requires one of the two criteria: a glomerular filtration rate, GFR, less than 60 mils per minute. Markers of kidney damage, including albuminuria, histology, or imaging. Prognosis of CKD by GFR and albuminuria. Classification includes the GFR and the degree of albuminuria. Definition recognizes severity and progression. As your GFR declines and is paired with albuminuria or proteinuria, the greater or worse the prognosis. For example, if you have a GFR less than 15 paired with an albuminuria less than 30 milligrams per gram, the prognosis is still pretty poor, but it's even worse if you have proteinuria. In other words, that protein level is greater than or equal to 300 milligrams per gram. Again, the worse the GFR, or the higher the level or stage of GFR, paired with albuminuria or proteinuria, the worse your prognosis. What is creatinine? Why is it used in calculating the GFR? Creatinine comes from breakdown of skeletal muscle mass and dietary meat intake, released into blood at a relatively constant rate in stable kidney function, which makes it an ideal substance for measuring kidney filtration. There are limitations of creatinine, variation in production and elimination. For example, your diet, especially if a lot of meat is consumed, muscle wasting syndrome, amputation procedures, and medications that are ingested. What is GFR, or estimated GFR, or estimated glomerular filtration rate? An estimated measure of the number of functioning nephrons, the filtering units of the kidneys, in other words, automated reporting of eGFR whenever you check creatinine, online calculation if lab reporting of eGFR is unavailable. One can use that. Uses creatinine and depends upon age, sex, body, and size. Race has been eliminated in the recent recommendations. A normal functioning kidney filters approximately 180 liters per day or 125 mils per minute of plasma. Normal GFR, 130 mils per minute for men and 120 mils per minute in women, and can vary in individuals and also can be impacted by your overall health. Serum creatinine. Serum creatinine is used to calculate the eGFR, as we stated before. Used alone, serum creatinine is not the best way to detect kidney disease, especially in the early stages. This is because a rise in blood creatinine level is observed only after significant loss of functioning nephrons, again, the basic unit of the kidney. Albuminuria. The presence of albumin, a protein in the urine, is considered albuminuria, often an early sign of kidney damage. It speaks to risk of progression. The greater the albuminuria, the greater the progression of renal or chronic kidney disease. It is an independent predictor for all-cause mortality. Here are other markers of kidney damage. Structural abnormalities on imaging, such as ultrasound. There may be structural damage such as polycystic kidney disease, kidney stones. Histological changes by biopsy. Electrolyte abnormalities. Delivering culturally competent health care. Be cognizant of cultural issues such as diet and religion, social, such as food, pharmacy deserts, trust, and linguistic issues, language barriers. Prescribing patterns, prescribing ACE inhibitors and ARBs for African Americans with diabetes who have hypertension and albuminuria. That has been a challenge over the years, thinking that African Americans should not get ACE and ARBs because they don't work in African Americans, which is not true. They may require a greater dose, but ACE inhibitors and ARBs, are effective and protective of the kidneys. Here are some risk factors that speaks to progression of CKD. Albuminuria, in other words, levels greater than or equal to 30 milligrams per day. That alone may contribute to disease progression. Hypertension. One size does not fit all. So we have to tailor our hypertensive regimen, blood pressure regimen, to individuals based on age, overall medical conditioning. For example, someone may be frail or have a muscle wasting syndrome, so we have to be careful. We have to also watch for poorly controlled diabetes. Acute kidney injury may 100% resolve itself, but if not, can lead to chronic kidney disease. Genetics. Some forms of diseases, such as polycystic kidney disease, can occur in multiple generations, including every generation, depending on whether that disease is autosomal dominant or recessive. Lifestyle issues, smoking, obesity, as well as metabolic acidosis because of the buildup of acid in the blood because of poorly functioning nephrons.